Good afternoon, everybody. We are back again after the lunch session, and we will be starting the session right now, which is the first post-lunch session for the two-day-long conference. We are in the Conference of Heart Failure Summit 2023, organized by CSI West Bengal. And to begin with this session, may I please request Dr. Achyut Sarkar, Dr. Shunip Banerjee, Dr. H.S. Pathak, Dr. D.P. Chakraborty to join the session as our respected chairpersons and panelists. And I would also request Dr. Avik Karak to present his presentation right now and requesting all the chairperson and esteemed panelists to kindly hold on to your questions because we have a dedicated 15 minutes time after every session to wrap up with. So if you have questions, if any, that can always be discussed at the end of the talk of all speakers. Over to Dr. Avik Karak. Thank you.
Good evening,
Avik.
everyone.
Fine. Please go ahead. Thank you.
So, I hope I'm audible.
Yeah, you are audible. Your slideshow presentation is there. We can see that case twist in the post-lunch session. And if you permit, I'll
Yes, sir.
read the first slide on behalf of
Yes, sir.
you.
Yes, sir. Definitely.
And that is because this is very important clinical twist. We actually have all clinical information, laboratory investigations and imaging available as of now. But the most important thing is thanks for selecting the case, Dr. Banerjee and Dr. Mishra. So this is a 48-year-old male who is smoker and also takes alcohol. So he has risk factor for coronary artery disease, but I am not saying that this patient is suffering from coronary artery disease. Actually, this patient is suffering from something which is progressive fatigability, abdominal swelling, bipedal edema, and probably up to this, we'll stamp this patient as a patient of chronic liver disease. But meticulously, somebody has to examine the JBP. We don't know whether the patient is in atrial fibrillation or not, although the rate is high. And we are sure that in view of the prominent Y descent, this patient doesn't have any physiological obstruction into the right heart failing. So with this, I take the opportunity to invite Dr. Avik. Please go ahead and present your thought process in this. Thank you.
Yeah. Well, thank you, sir. So, as Shuni Banerjee sir has aptly and very precisely and concisely described the clinical situation that we have in our hand immediately in the post-lunch session. So, I'll not be wasting much time. My job is to think about the various differential diagnosis and the etiological workup of the patient based upon that. So, without wasting time, so what do we have in our hand? The issues. Middle-aged male who is smoker and alcoholic. Both are significant risk factors, as sir said, both of coronary artery disease as well as other risk factors as well. Along with that, the patient has fatigability, which can have multiple and numerous causes. And one of the issues that can lead to fatigability is a low cardiac output state. The patient is definitely having a tachycardia with a blood pressure slightly on the lower side. The JVP on clinical examination is raised with a prominent Y descent. As sir appropriately said, we need to assess the other waveforms also, the presence of A wave, the X descent, and all. The only thing that we can definitely address or understand is that the patient is having a prominent Y descent, so probably there is no obstruction to the right ventricular inflow tract. And there is some amount of tricuspid, definitely there is probably a tricuspid regurgitation, but the etiology of the type of the other wave patterns is definitely going to be important. Also, the patient has icterus, ascites, and peripheral edema, probably leading to is because of the systemic venous congestion. So we have a state of progressive of sort of a right heart dysfunction or right heart failure sort of situation. So probably my differential diagnosis would be in the line of a constitutive pericarditis or some form of restrictive cardiomyopathy. a dilated cardiomyopathy with a predominant right heart failure, right heart involvement, a tricuspid valvular disease in the form of tricuspid regurgitation, right ventricular myocardial infarction, or cor pulmonale. Well, just briefly going through the various differential diagnoses that I've thought. Constitutive pericarditis, a chronic inflammatory process involving the pericardium leading to fibrotic thickening, scarring, and subsequently calcifications, which could be quite extensive and eventually can also extend into the myocardium. It's characterized by abnormal diastolic filling patterns, which may subsequently lead to impaired cardiac output and overt heart failure. These are the various etiologies of constitutive pericarditis, most important of which are post-cardiac surgery, then radiotherapy, different infections like tuberculosis, uremia, connective tissue disorders, and malignancies. And probably of all the things, probably the post-cardiac surgery is one of the most important things that is now very, very important in the developed country as well as in the Indian scenario now. TB definitely has to be kept in mind, especially in patients in the Indian context. And in this patient definitely has to be kept. And malignancy is also very, very important. Connective tissue disorder, hematoma, uremia, relatively less so. So if we look into the constitutive pericarditis, we need to look into the history, the various, whether the patient has any history of cardiac procedures, radiation, infection history. In the physical examination, we need to look into the patient has right-sided congestion, like JP will be engorged with prominent Y descent. X descent prominent is also very classical, the M pattern, Kussmaul sign, ascites, peripheral edema. Elevated pulmonary capillary wedge pressure and decreased cardiac output response to exercise can lead to fatigability and effort intolerance. And auscultation, we can find pericardial knock, which is a very classical finding. Now, lab ECG and X-ray, these usually do not give any specific diagnosis, and cardiac imaging like echo, cardiac MRI, or cardiac CT is very, very important to give us information regarding the anatomy and physiology of the patient. An echo features of both exaggerated ventricular interdependence and intrathoracic intracardiac discordance can be found in the form of respiriphasic septal shifting, abnormal beat-to-beat septal motion, or septal bounce. IVC usually is universally plethoric, and we can find annulus reversers wherein the tissue velocities of the lateral mitral annulus is less with respect to the medial mitral annulus. Chest X-ray can be suggestive if there is significant pericardial calcification, and CT MRI is diagnostic with the pericardial thickness more than 4 millimeter. And MRI can also give information regarding inflammation, and myocardial assessment can also be done. The invasive hemodynamics also gives sheds light upon the underlying etiology and the disease process, showing the various dissociations in the interventricular as well as intrathoracic and intracardiac dissociation. Grossly, I'll not be going into much of RCMP because the basic differentiating points with respect to CCP and RCMP is based upon the etiologies like amyloidosis, malignancies, idiopathic endomyocardial fibrosis, though they are less common nowadays. Clinical signs will have definite evidence of some form of a regurgitant lesion, both left and right-sided, ascites, peripheral edema. Then on imaging, we can find normal or reduced ventricular size, classical biatrial enlargement, and marked non-dilated left ventricle with normal contractile function. Cardiac catheterization can also give some idea when we can find a square root sign, and the treatment will be dealt on later. Coming to right ventricular myocardial infarction, it's usually associated with an inferior wall myocardial infarction. Rare to have a right ventricular myocardial infarction as an isolated situation. Patient will have chest pain, marked sensitivity to preload reducing agents like nitrates or diuretics or morphine. Right ventricular failure and elevated RV filling pressure despite a relatively normal LV filling pressure is usually found. Cardiac enzymes are usually elevated. Classic triad of distended neck veins, prominent Y descent, Kussmaul sign, clear lung fields, and hypotension. RV is more frequently associated with hypotension, cardiogenic shock as bradycardia. EKG will show ST elevation in the right-sided leads, isoelectric ST or ST segment elevation, and V1 associated with inferior wall myocardial infarction. And echo can show right ventricular dysfunction with regional wall motion abnormality associated with RV dilatation. Paradoxical septal motion can be seen, tricuspid regurgitation, and an RV performance index, RV-MPI of more than 0.3 is again very important. For pulmonale, a very important differential diagnosis in our clinical situation because of the chronic smoking status of the patient. For pulmonale represents, it's basically a pathophysiological constellation of symptoms which is produced by the alteration in the structure or the function of the right ventricle, which is caused by a primary disorder of the pulmonary system. It results of a result of increased right-sided filling pressure from pulmonary hypertension associated with the diseases of the lung. Classified according to the WHO into 5 types. Now, one thing we need to understand and keep in mind is that the right ventricle is always better adaptable to increased preload situation rather than the afterload. And that is why for pulmonale, which is a situation with an increased afterload, eventually right ventricle fails to compensate for that. And ultimately, a critical overshoot of the afterload leads to right ventricular dilatation, elevated RV-EDP, and an RV failure. Decreased right ventricular output ultimately leads to reduction in the LV preload, followed by a reduction in the LV cardiac output. Symptoms, fatigability, tachypnea, shortness of breath on exertion, cough, angina, chest pain can happen, hemoptysis, passive hepatic congestion can lead to icterus, anorexia, syncope, pedal edema. Signs, findings can be found in relation to the lung pathology. Parasternal heave, pulmonary regurgitation, murmur can be found. We can find a narrow splitting of second heart sound with a loud second heart sound. RV S3, S4 in the later stages, and TR murmur, a secondary TR due to RV dilatation. Evaluation includes chest X-ray, CT to evaluate the underlying lung pathology, EKG with evidence of RVH and RV pressure overload, echo with PAH, RV function, TR, probable etiology, and excluding the left heart causes needs to be seen. And right heart catheterization is very accurate in diagnosing. Coming to tricuspid regurgitation, the types, primary tricuspid regurgitation, wherein the pathology is in the right tricuspid valve apparatus. Secondary tricuspid regurgitation due to the right ventricular causes, and an isolated tricuspid regurgitation. If you look into the etiologies, Epstein's tumors like carcinoid myxoma, in iatrogenic causes like endomyocardial biopsy, transvenous pacing defibrillates, drugs like anorectic drugs, dopamine agonists, ergot alkaloids can also lead to leaflet damage, and systemic diseases like lupus, sarcoid, rheumatic diseases, endocarditis can also lead to a primary tricuspid valve regurgitation. Secondary TR is primarily due to a coexistent left-sided valvular and myocardial disease, pulmonary hypertension, pulmonary embolism, chronic pulmonary diseases, and the concept of an isolated tricuspid regurgitation wherein the TR happens in the absence of concomitant pulmonary hypertension or a coexistent left-sided heart disease usually happens in the elderly patients with a high prevalence of atrial fibrillation causing right atrial dilatation, tricuspid valve annular dilatation, and tricuspid leaflet malcoaptation, ultimately leading to an isolated tricuspid regurgitation. Echo, again, important things. Excessive motion of one of the leaflets may point to a traumatic chordae rupture, but in the case of redundant tissue may also indicate the presence of a myxomatous valve disease. A combination of thickened and restrictive motion of the leaflet may be caused by carcinoid. Tricuspid valve endocarditis can happen with IV drug usage, which is not that uncommon considering our present situation on the clinical case. The high ratio between the size of the TR color jet by Doppler and the right atrial area assessed by color Doppler echo may indicate the presence of a severe tricuspid regurgitation. Interestingly, if the patient has a massive TR, the peak velocity of the regurgitant jet may be paradoxically low due to the chronically elevated RA filling pressures, which can ultimately affect our diagnosis. Isolated TR in the presence or in the absence of a pulmonary hypertension, the right ventricular tends to dilate predominantly in the basal segments, leading to a conical deformation with more annular dilatation and an RA remodeling, which usually happens, as I said, in elderly patients with chronic atrial fibrillation. So as far as our case is concerned, depending, if we go back into the clinical situation, the patient presented with chronic smoker, alcoholic, fatigability, abdominal swelling and ascites, raised JVP, icterus, and low blood pressure with a tachycardia. So in this patient, probably our primarily concern will be constrictive pericarditis, a cor pulmonale, a tricuspid valve disease in the form of tricuspid regurgitation. With this, I would like to hand over the session to our next speaker, Dr. Shilanjan Roy. Thank you, everyone. Thank you, sir.